Thank you, Chairman. So first, I would like to thank Professor Sandicott and also the organizing committee for inviting me to this exciting conference where I've been learning a lot from the various speakers. We are all facing an epidemic of diabetes, and India is really, the home of a lot of people with diabetes. I have chosen this topic called personalized or protocolized diabetes care because I only got about 80 minutes. I thought I would try and share with you some of the data that we have really collected through the establishment of a Hong Kong Diabetes Registry back in 1995, where we actually used a nurse, a protocol, and just a simple database to actually implement what's the St. Vincent's Declaration of IDF many years ago, where they advocate people with diabetes undergo comprehensive assessment for risk factors and complications every year or every 2 years in order to detect these risk factors and complications for early intervention, given the fact that diabetes is largely a very silent and very indolent disease. So firstly, these are my declaration. And I think we as doctors and care professionals know that every person with a condition is different, is unique. They all have a set of attributes, the genetic factors, the epigenetic factors, behavioral factors, and also psychological factors, external factors, which actually make up one particular person. And so for the same disease, you will have different presentation. A person with diabetes can be young, can be old, middle-aged, can be lean, can be overweight, can be obese, can have all the 6 risk factors and complications that you can think of, like the eye, the feet, and also the heart, but no complications. On top of that, many of these people might have psychological and also behavioral problems. Because it is so complex, therefore, you give the same drug, there may also be different outcomes. And indeed, until recently, we don't really have a lot of problems because for those of us who've been around for a long time, really only until the last 15 years, we only had 3 drugs to deal with, just insulin, sulfonylurea, and then metformin. But because of increasing increasing research in this area, over the last 15 years or so, we see a proliferation of drugs, alpha-glucosidase inhibitors, TZDs, GLP-1 agonists, DP4 inhibitors, and more recently, the SGLT2 inhibitors. All these drugs can reduce glucose. Nonetheless, many of them have additional benefits, and sometimes they also have side effects. In a way, it also kind of reflects how complex the biology is. And therefore, if you can just touch a little bit of the biological pathway, you will have some benefit. And depending on whether this is linked up to a positive pathway or a negative pathway, you will have different side effects. And so, when we are dealing with diabetes, one of the biggest challenges is, of course, trying to get somebody to A1C goal. And of course, the A1C, we all now know, is not just biological, there's a lot of behavioral, and there's also a lot of psychological components to it. So the patient self-management and also the community support, the peer supports, the family support are all very, very important. And here we all, the previous speaker has just highlighted so important education is in diabetes. And together with these drugs, all these drugs, they can lower A1C, but along the line, they can have different patterns of hypoglycemia. They can also have different impacts on body weight, and at the same time, this body weight will impact upon blood pressure. Really, the body weight is a major predictor for blood pressure. And we know this double burden of blood pressure and blood glucose can have an immense impact on the clinical outcome. And currently, as I said, there are 13 in age of 56, okay? And actually, when they enrolled in the registry, their age was actually, they already have 5 years of diabetes. In other words, the mean age is actually 50 years. Half of these diabetes. At any one age, these people actually have 50% increased risk of major clinical events in terms of heart disease, renal failure, or death. So next time when we see a patient age 45, you must ask the disease duration. A person 45 with 15 years of diabetes behind him is very, very different compared to somebody who's also 45 but who were newly diagnosed. And very often people really don't know the disease duration. And even more importantly, we all know in Asia, in young-onset diabetes, classical type 1 diabetes is not common. Only about 10% of these young people have classical type 1 diabetes. 90% of these young people actually have so-called type 2 diabetes, but they are phenotypically very heterogeneous. Half of them are actually quite lean, and then half of them are obese. Compared to those people who have classical type 1 diabetes, which only make up 3% of the diabetic population and 10% of the young-onset diabetic population, their outcome is a lot worse. At least in Hong Kong, when we have a reasonable, good healthcare system, nobody's denied healthcare, nobody's denied insulin. You could see that a bit like jostling. These people, type 1 diabetes, they're very, very good outcome. However, because they're under good care and they actually present early because of ketosis, whereas those people who are lean or who have type 2 diabetes, they actually very often present late and frequency defaults because they never have ketosis. But of course, they also do not have good control to actually, and as a result, they have all these complications. The lean type 2 diabetic tends to be, have renal failure, whereas actually the obese type 2 tends to have cardiovascular disease. And here, I think increasingly the literature is highlighting the importance between age, because as we all age, biologically we fail. The age of onset, which actually reflects the disease duration. So it is these three factors which actually drive the very high rate of cardiovascular and renal disease in these individuals. Here you could see that at the age, these are the age of enrollment, okay, 40, 45, 50, and 55. But as time goes on, these people who have young onset diabetes, these are diagnosed before the age of 40. At any age, these people actually, young onset diabetics, actually have much higher rates in terms of cardiovascular disease, kidney disease, and actually all-cause deaths compared to those late onset diabetes. So again, highlighting really the interactions between age and also disease duration. And we've also, through this registry, we have expanded our program to a JADE program, which is using a web-based disease management program to enable clinicians to collect data in a structured manner using the same protocol. We were able to demonstrate the same pattern among, these are actually 40,000 people enrolled from 11 countries. And again, we were able to show that consistently in all these countries, 1 in 5 actually have young onset diabetes. And compared to the late onset diabetic subjects, all of these people were actually less likely to attain an A1C goal of less than 7%. So here, the young people, 1 in 5 of these young people with diabetes who are young, actually are very high risk. Apart from this kidney disease, young age, the other third important type of individuals are those who got depression. I think increasingly people notice that actually many people with diabetes have depression, and the co-occurrence of depression and diabetes markedly increase the risk of death and particularly stroke. And again here, using the registry, once we have a good database, we can actually collect other important data in a very convenient manner. And this is again another study which is in 6 centers in China, where we actually, this is actually firstly in our own setting in Hong Kong, where we firstly validate this PHQ-9, which is used to screen for diabetes, screen for depression. And again, conventionally, people use PHQ-9 greater than 10 as depression. And we found that actually overall, 8% of people have depression, and more so in women. However, if you actually use the psychiatrist interview as a gold reference, then at least in Chinese, actually a cutoff value of 7 is actually more optimal in detecting depression. And then we found that actually nearly 1/5 of these people actually have depression, and once again more likely in women compared to men. And this is actually very important because it does affect compliance. And how do you check compliance? And this is actually a very useful 4 question, and that is the Molesky medication adherence. Have you ever forgotten to take your medicine? Are you careless at times taking your medicine? If you feel better, did you stop medicine? If you feel unwell, would you stop taking the medicine? And when you actually start measuring things, you always have the impression that people are not compliant. But when you actually start measuring, then it's actually very distressing to find that actually 50% of people actually said yes to 2 of these questions. In other words, 50% of our people are actually not taking the drugs. And what's important is actually the drug adherence, and you can see that actually people who were actually more depressed people who are depressed, they're actually more likely to be non-compliant. These are depressed people, and these are non-depressed people. This is the overall. And then they're actually are less likely to be compliant and more likely to be non-compliant. And as a result, these people with depression are also more likely to be not at goal, and also more likely to have hypoglycemia. Another group of individuals who are very difficult to manage. But can we find them in order to manage them? When we actually look at this database, again, which is across 6 diabetes centers, using a protocol to detect systematically these risk factors, we're able to show what are some of the predictors for poor glycemic control. We just heard depression is actually an independent predictor for poor glycemic control. Once again, showing it's the young people who actually have poor glycemic control, people with long disease duration, people who smoke, and people who have low socioeconomic class. Now, if we add a few more variables, then we can find that people who have high BMI, and understandably people who have high insulin usage, are also more likely to have poor A1C. But what's interesting, because we also collect self-care data, we found that people who were non-adherent to diet and also who are non-adherent to drug were also more likely to be, have poor glycemic control. But what's important is, once you actually put these 2 adherence indexes into the model, the association between depression and also poor A1C was attenuated, suggesting that really depression, the association between poor glycemic control and high A1C might be mediated by non-adherence. So finishing off, I think, given 5 minutes, how can we actually identify from these 100 patients, some of these high-risk patients, those who've got kidney disease, those who are actually young-onset diabetes with complications, those who are depressed, who might be non-compliant? I think these are some very quick questions that we can ask ourselves when we see a patient's A, B, C, D, young versus old. Body weight, I think really just looking at the body weight, particularly central obesity, will give us some guidance regarding management and choices of drugs. Complications, particularly renal complications and cardiovascular diseases, we really have to start using medications associated with lower risk of hypoglycemia. But if we don't have time to look at the eye and the feet, then think about disease duration. At least ask about disease duration. And if people have more than 5 years disease duration, certainly above 10 years disease duration, we must start screening for complications. And most importantly, start understanding a bit about the etiology, the education, empowerment, and evaluation. So to finish off, I think looking after people with diabetes is extremely challenging, as we already heard. It's a complex protocols because it's complex phenotypes, complex behaviors, non-adherence on the patient's part, and also clinical inertia on the doctor's part are really real challenges. No information, no decisions. 3 solutions is, I think, we must task delegation. We must actually make other people help us. Personalized information and shared decisions is very important, and ongoing support and evaluation. These are evidence-based. This is actually based on a meta-analysis showing different initiatives targeted either at the system, at the patient, or at the doctors that can make a difference to A1C. And you could see that persistently it is promotion of self-management, team changes, in other words, using task delegation and also sharing of responsibility with a common goal to manage the patient can actually has the greatest effect size in terms of reducing A1C. But you could see that many other initiatives such as electronic patient registry, patient reminders, audit and feedback, clinician education reminders, all these make a difference. Now, how can we put all these initiatives into a total integrated system to make it happen? And so I finish off with this JADE program that some of you might be participating. And this is basically really demonstrating the point that in order to personalize care, I think we need to have a protocol. And essentially, by changing the workflow, we actually introduce complication screening session where these patients undergo this assessment once every year or every 2 years, where they have their eye, their feet looked at, urine and blood tests, all in one go because they're interrelated. Put them on a registry. Use the registry to actually generate personalized reports in terms of risk predictions, show them the trend of their ABC target, these are the multiple risk factors, together with some decision support, just like what Dr. Ramachandran has done, and then to actually feed back to the patients and also to the doctors in order to make changes. I don't have time to show you, but after 7 years, we were really able to show that by using this kind of information technology and team-based care and using a protocol, we can really make quite a lot of difference in terms of patient management, reducing clinical inertia. So finishing off, I would like to invite some of you to join our program. It's a Diabetes Preventing program where we really concentrate on disease management, which will be held in Hong Kong in May. Thank you very much.